Good afternoon, and thank you for joining us for today's webinar on payment reform, exploring technology implications for health insurers. Today's webinar is presented by executives from Medica and HealthEdge, and it is presented in collaboration with the Healthcare Executive Group. To start things off, I'd like to introduce today's speakers. Today we're joined by Andrew Davis, the Vice President and General Manager of the Medicare segment at Medica, and Harry Merkin, Vice President of Product Marketing for HealthEdge. A quick overview of today's webinar. Today, we'll start by taking a look at the market dynamics currently impacting payment reform. We'll specifically take a look at the shift to value-based models and take a deeper dive into the MACRA rule and understand what it means for health insurers, as much of the industry conversation has currently been centered around the impact of this rule on providers. From there, we'll hand things over to Andrew of Medica, who will introduce the organization and explain a bit more about Medica's experience with payment reform and specifically MACRA. He'll talk in depth about the technology considerations for payers as they work through their experience with this new model. Finally, we'll shift into a Q&A where you can submit your questions via the chat dashboard and the WebEx dashboard, and we'll answer them in the order that they come in. So I'd like to turn things over to Harry, who'll kick things off to speak about market dynamics.
Thank you very much, Melissa, and thank you in advance to Andrew Davis from Medica, and of course thanks to HCEG for facilitating and making this webinar possible. Significant milestones in place and goals for the transformation of programs from fee-for-service to value-based. And they've actually hit their first milestone this year, which is 30% of all reimbursements being tied to value. They're targeting 50% within the next 2 years and 75% of all reimbursements to be tied to value by the year 2023. Andrew's going to actually provide even more color to those statistics with regards to alternative payment models as we go. And just on the bottom, you can see how CMS defines value-based. It's about better care, it's about better health for populations, and it's about lowering the cost. So it's kind of version 2.0 of the triple aim, if you will. And so what does this mean? Well, when the Affordable Care Act was passed in 2010, the first wave of change was about access to insurance. And somewhere around 9 million Americans are insured now that weren't insured then, and that number continues to grow. The second wave of the Affordable Care Act is about containing cost and about this value-based transformation. So what does that mean? Well, it's about accountable care, it's about coordinated care, it's about increased risk on the part of the different stakeholders, it's about having different kinds of controls in place and different kinds of measurements. And very importantly, it means all the members of the care team across the ecosystem have to have the same information in order to make the right decisions. And very notably, and this goes along with both trends that I'm talking about, growth in government-sponsored programs, namely Medicare, Medicaid, and duals, have been and will continue to be the fastest growing segment of the healthcare delivery system. So just in the last 3 years, Medicare has gone up 10%, but Medicaid with the Medicaid expansion is up 35%. So, contrary to some of the news headlines, many states are embracing Medicaid expansion, and, Andrew will give us great experience from the front lines on the Medicare front to explain what's happening there. We know that 10,000 baby boomers are turning 65 every single day. We know that Medicare, enrollment is growing, and there's a lot of needs that come with that. Many of those people come into Medicare with existing preconditions and require all kinds of different care that they might have been getting otherwise. And the next slide is actually derived from a recent State of the Payer survey that we at HealthEdge conducted, in which we asked payer executives what's on their mind and what's important to them, what are their priorities, what's impacting their business. And the specific question here is about which of the following types of healthcare delivery models is your organization planning to participate and support in the next 3 years. And the top two, not surprisingly, number one on the hit parade is the transformation to value-based payments. And number two, closely behind, is the expansion of Medicaid and the growth of Medicare. So supporting the points I made a moment ago and reflecting the reality in today's market, value-based payments and Medicare, Medicaid expansion are very much keeping people awake at night. And then just a couple of months ago, McKesson came out with a survey also of payer executives, also focused on value-based reimbursement, and the testimony from that survey was similar and very strong. If you look in the upper right, fee-for-service is going to be dwarfed in the next few years by value-based reimbursements, according to these payer executives, and 58% said they're already on the continuum towards value-based, and that was a significant increase just from 2 years ago. And 74% of health insurers are tracking patient outcomes. So better quality care, better outcomes, lower cost, it's all part of the same equation. And actually, very positive news on the left-hand side, 61% of the payers that were surveyed in this survey reported that they expect positive financial impact. So while there's additional regulations, additional measurements, additional tracking, additional reporting, and accountability involved, they also see positive impact based on the outcomes to the members. And then lastly, but not least, directly from some three specific executives, and these quotes were from the main stage at the World Healthcare Congress in April in Washington, D.C., and if you attended, you might have seen this. These three gentlemen were on a panel together, and I was jolted by the CMO of United, who said, we've got $100 billion in annual reimbursements, and today, in early 2016, 43% of that money is tied to value in some way. And of course, there's the Aetna 2020 program, where Mark Bertolini himself has declared that by 2020, 75% of their claims are going to be value-based. And then the CEO of Johns Hopkins Medicine talking about what value means, innovation, and directly in the payment systems. And then the industry experts are chiming in as well. And Jeff Rivkin from IDC says, and I quote, as Medicare goes, so goes managed care. And that's not a new saying. That's been around for about a decade. It starts with e-prescribing. It goes through the entire Affordable Care Act. Commercial payers will soon see hospitals and large physician groups knocking on their door, coming to the contracting table with alternative payment designs, and payers will need to be able to react. The only certainty is that change will continue to shape the healthcare market, and the successful payers will be able to meet that challenge head-on with insight, agility, and operational efficiency. And Constance Soquist from Gartner, similar recommendations. She talks about the digital strategy that payers must have. And furthermore, digital business is not solely focused on an element of technology, but it's on the broader business opportunity to compete and creating disruptive competitive advantage. Driving payers to embrace the digital model means the integration of people, technology, and things. So what does this mean for technology? How does this translate? What do we need to be doing, thinking about, and taking action on? As Jeff Rivkin said, agility is key. So the ability to move quickly, nimbly, adapt, launch new business models, launch new benefit designs, reuse what we've already got in place very quickly, share the relevant and actionable information with those on the front lines who need to make decisions at the point of care. Of course, the cost piece, which is efficiency. So automating processes wherever possible, getting humans out of the process where that is practical, but also making sure that our competitive position is at its best. And then finally, transparency. And this has many meanings, but in this case, we're talking about putting the patient at the center. We're talking about, as I mentioned a few minutes ago, a 360-degree complete and longitudinal view for all the members of the care team. And then on the member side, making sure that their experience is delightful, engaging, and that they want to come back. Okay, we're going to pivot now with that as background and talk about MACRA. What is MACRA? So it stands for the Medicare Access and CHIP, which is the Children's Health Insurance Program, Reauthorization Act of 2015. And the law was drafted in 2015, and the rule by CMS was put out in April of 2016. And the law was voted on by a huge bipartisan majority of 92 senators in the U.S. Senate and 367 representatives in the House of Representatives, so it is viewed as election-proof no matter what happens this November. And it's a 962-page rule, so there's a lot of complexities there, and I'm sure Andrew spends many evenings, poring over the details, and he can tell us about that. But basically, it's a major push by CMS to move from fee-for-service to value-based reimbursements. And it puts in place a common set of quality measures that are set to begin on January 1st of 2017. That's right around the corner. The measurements themselves have not been fully baked or announced, and they're scheduled to come out in November, which is causing additional headaches. Though it's very notable that the law was written and the rule was documented stating that these measures are designed to start in Medicare and move into Medicaid over time and ultimately into commercial payments. So this is a Medicare-only program for the time being with written documentation stating that it's going to move beyond into all fronts. So what does it mean to the payers? Well, I think Andrew's going to be more articulate about this than I will with some tangible examples, but starting January 1st, with the advent of those measures coming out in November, the health insurers have to be ready to record and crunch some of those quality measures. They've got to be able to adjust the contracting, as Jeff Rifkin talked about, with their provider network, and then ultimately be able to reimburse appropriately, embracing the value-based models that MACRA dictates. And obviously, the technology infrastructure has to be the key enabler for all that to happen. Just to spend one more minute on MACRA, and then I'll turn it over to Andrew. So there was something called the SGR, the Sustainable Growth Rate, as well as meaningful use. And MACRA actually replaces both of those. And there are a lot of people cheering, particularly around meaningful use. But the Medicare physician fee schedule will now be fixed in two different schemes. So there are actually going to be two payment regimes, and providers are going to have to qualify. And the advanced alternative payment model will provide higher level of incentives, also penalties, but the reward will be for participating in higher level of risk-bearing arrangements. CMS is estimating that somewhere between 10 and 20% of all providers will qualify for the APM designation, and the rest of the providers will fall into MIPS, which is Merit-Based Incentive Payment System. CMS is putting a fund aside of somewhere around $800 million, and they expect that fund to be cash neutral. So they're going to hand out incentives in that amount, and they're going to impose penalties in that amount to balance the books. So with that, I'm going to step aside and hand the baton over to Andrew Davis, who heads up Medica's Medicare unit, to give us some more specifics on what Medica is doing to prepare for MACRA and payment reform. Andrew.
Thank you very much, Harry, and good afternoon or good morning to those of you on the West Coast. It's a pleasure to spend a little bit of time with you today and share some of Medica's thoughts and observations related to MACRA, and to put into context how we're thinking about it, given our ongoing focus on reimbursing physicians in such a way that really is driving, higher quality, improved value, and ultimately lower costs. Again, my role at Medica is I run our Medicare segment, which is about $1 billion line of business for the organization, and I'll talk a little bit more about that business in a second. But for those of you not familiar with Medica, we are an independent, non-for-profit health insurance organization. We are proudly based in Minnetonka, Minnesota, and for those of you that have never been to Minnesota, Minnetonka is essentially a western suburb of the city of Minneapolis. We have proudly last year celebrated our 40th year of doing business. We are essentially an upper Midwest health plan. So we cover Minnesota, the Dakotas, 13 counties in western Wisconsin, and we have most recently moved into Iowa and Nebraska last year, and we are really excited in that we are entering the Kansas marketplace this fall. We cover 1.7 million individuals, which is really the high point for us as an organization, so we're at our highest point in terms of total membership. And a little bit about our government programs business. Our Medicaid business is quite substantial at 357,000 members, and our Medicare membership is just under 200,000. Our Medicare membership is at its highest point it's ever been, and we're essentially the 12th or 13th largest private Medicare plan in the country. For our Medicare, we cover beneficiaries all throughout the state of Minnesota. So obviously that's the metro area and rural parts of the state. And we also have a significant presence in North and South Dakota, as well as the 13 counties in western Wisconsin. And the reason I bring that up is because this question of MACRA and the two tracks really covers our footprint, our marketplace, in a pretty significant way. So in the metro area in Minneapolis, we have large vertically integrated health systems that are active and very effective participants in Pioneer ACOs and the Medicare Shared Savings Program. And so they're clearly lined up to take the APM track. Yet we have thousands of small independent community-based physicians that are practicing medicine and serving our beneficiaries in the rural parts of Minnesota and also in the Dakotas. So this question of success in MACRA is important to us because, just quite frankly, we have a lot of beneficiaries that are going to be flowing through both sides of the equation, MIPS and APM. So let's talk a little bit more about Medica and our experience with alternative payment models. This clearly is an area that we've invested a lot of time and energy and thought around. And, quite frankly, for 16 years plus, we've been, actively using alternative payment models, both within our government programs and commercial business. What I did here was I identified some APM components that we have active in the marketplace or have had, in the recent past. So we have a lot of contracting that is focused on quality measures. So think of this akin to the MIPS program, where there are quality measures tailored to a particular product or tailored to a particular population or tailored to what the provider group or system is really aimed as their priority. So a lot of work around quality, again, akin to MIPS. The goal ultimately is to reduce the reliance on the fee-for-service payment rates. So most of our contracts are really aiming towards, either less of a reduction or more of that fee-for-service payment going at risk. We have full-on capitation payments. We have at least one contract where it's 100% at risk for capitation. That we have a number of those within our dual-eligible special needs plan. We have risk sharing, both upside risk and downside risk on improved outcomes. And then most importantly, we have some clear linkage related to quality and performance for STARS and for HEDIS. So, this question of MACRA is a very important topic, for most health plans. I'll really speak for Medica. in that we have been really invested in APMs for quite some time, and we've been wanting HHS or CMS to really bring this more into the forefront within Medicare fee-for-service, which I'll talk about in a second. They did do that through the ACA, but I think what we're ultimately looking for is some real financial incentives to be brought to bear to really drive and influence physician behavior around Medicare fee-for-service care being delivered to beneficiaries. The one thing I would say related to ACOs that people may not be aware of, I think Medica, quite frankly, is a leader in the area of ACOs, particularly on our commercial book of business. We have 7 active ACOs in the marketplace today that we offer through our MyPlan private exchange. These are health system-based products that commercial employees or employees of organizations that we serve through our commercial accounts can choose from. The membership is attributed to that health system, and that health system is accountable for delivering that care. So again, this I'm putting MACRA into context in terms of Medica and our focus on alternative payment models. And ultimately what I'm going to be really speaking about is how do we align really the innovative work that's been happening in the marketplace to what MACRA is trying to introduce within Medicare fee-for-service. And I think that's really the sort of the fine line that a lot of payers are trying to figure out how do we best do that, and how do we best do that with our providers. So on the next slide, I'm really going to go back and revisit the information that Harry shared with you, because I think this is a really important slide and set of information to really put into context MACRA. So as Harry indicated, and as HHS said in the early part of 2015, their goal is to drive 30% of all payments, tied to quality or value through alternative payment models. And you can see here in the little fine print, it says categories 3 for 4. So I'm going to get a little wonky and a little technical here, because I think it's important to define what exactly is HHS defining as sort of success in terms of these alternative payment models. And categories 3 and 4 would be category 3 is essentially alternative payment models built on the fee-for-service architecture, and category 4 would be population-based payments. So the vast majority of the 30% that HHS said earlier in March of this year that they've achieved really is coming from the 477 Medicare ACOs that are in the marketplace today. So those ACOs are essentially creating that 30%, and that is a fantastic accomplishment for the program, for HHS, for CMS. It was I think one of the key success elements of the Affordable Care Act. We can all have our opinion, professional and personal, on really the effect of the Affordable Care Act. But I do think one of the things that has undeniably been positive, net positive, really has been the incentives and the innovation that's occurred within Medicare fee-for-service, and really bringing to the forefront these types of alternative payment models into the marketplace. But the real question, though, that that I think about, and I'm sure many of you think about, is that that while 30% of all payments within fee-for-service, Medicare fee-for-service, are tied to APMs, I think the question is, so what has, though, been the impact of that? How has that been, really bent the cost curve, so to speak? And just to put things into perspective, I think earlier this year, HHS essentially said that their Medicare ACO programs have delivered, somewhere in the tune of $411 million of savings. $411 million, and that's a decent number. But put in the context of how much Medicare fee-for-service is going to pay physicians this year, which is $380 billion, that's a 0.1% impact on the total Medicare fee-for-service spend. So what MACRA, what this legislation really, in my opinion, is intending to do and that we hope to do is to bring forward additional financial incentives, more skin in the game, to more dramatically influence physician behavior, to have a much larger impact on really the cost within the Medicare program. So again, wanted to sort of put into perspective that ACA drove a lot of innovation, Medicare ACOs, next generation ACOs, a number of different components that are alive and well within the marketplace, but the net impact on the total program costs have been, quite nominal up to this point. So, I think Harry is right. I spend the vast majority of my evenings reading the MACRA legislation, front to back, up and down. That's a joke, guys. I actually don't do that. But I've read it quite extensively. With that Medica, we have studied it extensively. And what I tried to do in this slide was to really identify and to point out for those of you that are maybe not close to this topic, really what are some of the consensus observations within our organization at Medica, but also, quite frankly, the industry. So this isn't necessarily a Medica-specific observations. What I've done, because we were actively involved in our comment letter process to the proposed rule for MIPS and APM, was I basically studied, at least 35 different comment letters, both from the large payer side, the regional payer side, the American AMA, American Academy of Family Physicians, et cetera. And I think what I've tried to do is save you a lot of time and energy in reading and to really boil down to some, high-level areas of consensus and key observations that you probably are reading about. These aren't necessarily new and late-breaking news, but it gives you a sense as to where there is some clear consensus within the industry, both on the payer and the provider side. And it's certainly not an all-inclusive list, because there are a whole host of really technical concerns that both payers and providers have related to MACRA that has been shared with CMS. But I do think there's, really getting to the first point, I think there is consensus that we really view MACRA as a critical event for the Medicare fee-for-service program, and that it can really be an improved accelerant for the ongoing transition to value-based payment over volume. And I think there's also a real view that it's really bringing Medicare into the real world, or bringing it into this century, in terms of almost equalizing or mimicking what is alive and well within the market today, both within the Medicare Advantage market, Medicaid market, and commercial market, and what we're seeing on the exchange front. So a lot of positivity and appreciation for what this legislation is aiming to do. Having said that, I think there's some real concerns around the deployment of this and the adoption related to it. One area that's really, I think, of concern for our organization and for health plans that are in the Medicare Advantage space is the fact that APM models under Medicare Advantage today really can't be included in the definition of an APM under Medicare fee-for-service until at earliest the year 2021. So that's 5 years away until we can basically have providers take advantage of the excellent work that's being done between providers and payers in the Medicare Advantage space. I mean, Medicare Advantage is really, in my opinion, is the gold standard for really effective contracting in the marketplace today. And again, that is not included in the definition for the first several years of what can be counted as the track for the APM track that would be included in the all-payer track, again, sometime after 2021. And I think really the concern is that the Medicare program and providers are not being able to take advantage of that innovation. And what it's essentially doing, it's creating bifurcation within the health system, within the provider community, around having a different set of incentives for fee-for-service and a different set of incentives for Medicare Advantage. So there was a lot of requests for CMS to revisit that and to really push Medicare Advantage APMs much sooner into the deployment of MACRA than it exists today. I think there's also some real concern around kind of the conflict on the quality measures between the CMS star ratings for Medicare Advantage and the MIPS quality measures, and that there needs to be alignment. I mean, ultimately, what we don't want to do, I think, as an industry, is to create one set of quality measures for a Medicare beneficiary who's being serviced under fee-for-service, and a different expectation around quality for a Medicare beneficiary who's being serviced by a Medicare Advantage plan. And so there definitely is not alignment today, and the clear, I think, ask of the industry has been really force those into alignment, because the administrative burdens associated with particularly for MIPS are going to be large enough as they stand today, that you really don't want to add two different sets of competing quality measures, which are very burdensome and very difficult for providers to even absorb and to effectively manage. So I think that definitely has been a stated concern. Third, the next would be really the adoption across all provider types being a key and a concern. And you've probably read that congressional testimony. I think last month in July, the acting commissioner even said that he'd be open to delaying MACRA, really due to the concerns that many senators on the Senate Finance Committee had related to the impact of deployment of MACRA for smaller, independent, and rural providers. Because, as Harry indicated, related to technology is going to be a very critical enabler of success within the provider office in order to pull this transformation from volume to value off. And so there's definite concerns being raised again by AMA and the American Academy of Family Practice, Medical Group Management Association, to make sure that providers are in position and that they're ready. And there's real concern that they cannot effectively invest in the informatics, the technology infrastructure, and really the overall care management competencies that they're going to need to develop. Because for many physician practices, this is EHR, or meaningful use, on steroids, and it's going to be a really important. It's going to be the most important element of the ultimate success of MACRA is provider adoption and of the effective transformation to value-based the practice of medicine. So definitely that is a big concern that has been expressed both from the payer and the provider side, but I'd say probably a little bit more vocally and directly from the provider community. And I think last but certainly not least is really being mindful of the unintended consequences of consolidation. As I mentioned before, and again, that context slide around the 30% of all payments being tied to some type of APM, you have 477 Medicare ACOs, including Pioneer ACOs, that are operating today. Well, they have a significant head start on MACRA as compared to independent, smaller, community-based rural physicians who are most likely going to take the MIPS route. And as Harry indicated, by far and away, MIPS is going to be the highest volume of, an estimated 760,000 clinicians will be in the MIPS track, somewhere between 30 and 90,000 in the APM track. So it has a it has a bigger impact on a larger number of physicians, the MIPS track. But that is, again, as I stated earlier, is a significant step up in terms of what they need to do in order to be successful on that track. And they just might be forced from a strategic standpoint, from a capital investment standpoint, and from a competency standpoint to strategically align themselves with larger either hospitals, vertically integrated systems, et cetera. So really I think the concern is MACRA could push consolidation just because of the inability of certain segments within the provider community unable to effectively deploy the law. All right. Preparing for MACRA. So I want to just share some ideas around the way that, quite frankly, we're thinking about it at Medica, some of the things that we are actively doing, just, as a best practice sharing. First and foremost, as I indicated earlier, we're doing a lot of APM work today across multiple business segments within Medica. And so, the natural thing for us to do would begin to say, okay, here's what we're doing today. How do we align with really focused on our key providers, the APM track? How can we begin to link what we're currently doing, what we're currently contracting, to what the provider's MACRA strategy is? Pretty straightforward. You would assume that we'd be doing that. But the second point is, you really got to ultimately engage your provider partners around what they are thinking and what they are doing around MACRA. So we're actively having those conversations to really understand, okay, how are you going to absorb this? How are you going to deploy it? How does this change the way that you think about a Medicare beneficiary? In one conversation with a particular provider partner, it was, very evident that they, and this is an organization that's participating in a Medicare ACO project. Their commentary was essentially along the lines of, well, we're going to need to treat every Medicare beneficiary the same, whether it's fee-for-service, Medicare Advantage, and we got to basically build the workflows now around that beneficiary. So where in the past they might have been able to offer sort of a different area of focus slightly between contracts, between different payers, I think what they're coming to the realization to is everyone's got to be treated the same. Therefore, you may begin to see some uniformity in how they contract with let's say Medicare Advantage plans. But you don't know that until you start talking to them and asking those questions. So again, really the engagement with the provider partner is going to be an important part of our strategy to really figure out how do we optimize their activity and our activity to get to a mutually beneficial outcome. Certainly, it's also to find ways that we can enable their adoption. I mean, we want physicians to be successful in this space. We need that to really help our bottom line and, most importantly, our beneficiaries. And we routinely are talking about the issue of data and analytics and how we can support that. In many ways, payers are in a better position than providers are, just given our core competence in the area of risk management and population health management. I'll talk a little bit about that in a second. Definitely, we are focused around quality and aligning our quality focus to their MACRA strategy so that we're, basically spending limited resources, limited staff time on the things that are most important to both of us. Second to the last is we're really beginning to spend more time at looking at quote-unquote efficiency as part of our assessment of providers. I mean, if you think about it, MACRA truly is about bringing forward a much bigger set of carrots and sticks that are really looking to force providers to reduce that unnecessary or low-value care, the quote-unquote 30% of spend that is unnecessary. And if you can begin to assess how providers are performing today, why wouldn't you want to work with those that are actually operating, much more effectively, even without MACRA, and try to leverage that right out of the gate. So we're spending a lot of time on that because ultimately we want to be spending probably more time and more money with those providers that are just quite frankly higher performing. And last but not least, is really the engagement around CMS. And even I had a conversation with CMMI earlier this week, and I do believe that CMS is really committed to, is doing everything they can to make this work within the marketplace, and I think are open for a different set of conversations with providers and payers around innovation, around flexibility needed, and so I wouldn't give up on trying to work with CMS in a partnership-oriented way to really help us, execute this type of transformation within the Medicare program, both on the fee-for-service side as well as continuing to drive deeper APM utilization within the Medicare Advantage space. So those are some of the ideas and things that we're doing to prepare for MACRA. I wanted to touch real briefly on what Harry mentioned in terms of the role of technology. Technology has been a very important enabler for Medica to really advance on the APM front for many, many years now. And I think one opportunity for payers obviously is going to be how we can enable providers to succeed really at risk and population management, because that's ultimately in a big way what MACRA is thrusting on them. So I'd be looking at opportunities that can be pursued related to supporting new payment models, that you have the technology that can support that type of payment model reform and delivery, that can really provide the ongoing quality performance management, real-time, more improved timing of information related to how things are actually performing within the population that the physician group is seeing. So a lot of opportunities with data and analytics. Actuarial insights are going to be really important for providers moving forward under the MACRA concept. And certainly, last but not least, is really two-way integration and more deep integration with key provider partners, definitely on the APM front, where it's just going to be incumbent on both parties to share information, to identify where there's opportunities, to move more quickly on gap closure. But technology is going to be an important part to that. And I know as a leadership team, at Medica, we spend a lot of time on making sure that we have the technology to enable the type of transformative progress that we need to make as a payer and that we need to make with our provider community. And MACRA just, creates even a higher bar and more urgency to make sure that type of technology, roadmap or footprint is alive and well in our organization. And then the question is, how do we then extend our technology capabilities to support the provider and what ultimately they're challenged with? And then last but not least, it wouldn't be a Medica discussion if we didn't really end it with the thing where we need to start, or the area we need to start, and that's our members. So, we're very focused on our membership as we think about our provider payment journey, and that, ultimately our focus in this area is really tied to high quality, better value, and lower cost for our consumers, and that's a ongoing call to action, ongoing value for us within Medica, and that's really driving really our passion around provider payment reform, Medicare reform, and then ultimately it's also to help really help sustain the Medicare program and more broadly the U.S. healthcare system for generations to come. So this is an exciting time, as I say all the time within Medica. This is maybe the most exciting time to be a professional working within a health plan, working within the healthcare industry. MACRA is a golden opportunity that that is going to benefit not just the Medicare program, but I believe the broader healthcare ecosystem. And I think we're well on our way to to addressing some of the challenges as well as the opportunity that MACRA presents. So with that, I just want to thank you for your time, and I'd be happy to take any questions with Harry. Thanks.
Thank you so much, Andrew. We have reached the Q&A portion of today's session. So you can submit questions via the WebEx dashboard. Please make sure that they're sent to all of the panelists so that we can see your questions, and we will answer them in the order that they're received. While we wait for your questions to come in, I'd like to go ahead and introduce Ferris Taylor from the Office of the Chairman of the Healthcare Executive Group. Ferris. Ferris, are you joining us?
Sorry, I was on mute, Melissa. Thank you, Melissa and Andrew and Harry and your teams at Medica and HealthEdge for putting together this webinar. All of us on the call today have appreciated the insights and information and analysis and your experience that you presented in such a clear and concise manner. And on behalf of the Healthcare Executives Group, I want to thank each of you on the call today for your interest and participation. While you're submitting your questions, I have to note that I was particularly interested myself in this version 1 ACA to version 2 ACA that both Harry and Andrew talked about. It strikes me that version 1 of the Affordable Care Act, or the ACA, was really accessible care. And now this is a great transition to the affordable care components of what we need in healthcare. And putting together that complete and longitudinal 360-degree view that everyone in the marketplace is going to need to be able to accomplish the affordable care components of what's ahead of us is very interesting. This discussion has been great in that sense. On behalf of the Healthcare Executives Group, we value Medica and HealthEdge's membership and sponsorship of the organization, and more specifically, their contributions to the collective knowledge that we all need in healthcare. And this webinar is an excellent example and a telling glimpse into the thought leadership and the innovation mindset that HCG has been known for the last 26 years. For those of you that are not familiar, I'll cut my comments short. You can go to hceg.org and learn more about the organization. We're a network of executives that meet annually but interact quite regularly through many channels of communication, including webinars like this, blogs, newsletters, white papers. And the organization facilitates those discussions, which we're doing here today. We are currently, as the slide shows, gearing up for our 2016 forum, September 12th through 14th in New York City. Our theme is healthcare, and we had disruption. We crossed that out and moved it to innovation, and we believe that's the new norm. We'll be discussing how technology, payer-provider, consumer relationships, and market dynamics are accelerating the transformation of healthcare. So we'll have industry experts who are leading disruptors and innovators to discuss these issues. Of note, and Harry had pointed it out, Constance Soquist from Gardner is going to kick off the conference with a keynote discussion. So if you want to get her insights, do go and sign up to register. There are a few seats available. We limit the attendance. So if you want to join us, you can email Juliana Ruiz at just jr@hceg.org or go to hceg.org and get more information and plan to come and continue this discussion with us. Hope to see you there. Melissa, are the questions coming in?
Yes, they are. So I think we're going to kick things off. Thank you, Ferris. All right. So the first question goes to Andrew. Andrew, when you were implementing your MA, APM, and MIPS with your book of business, what were some of the key challenges that you encountered and how did you overcome them?
Key challenges, I'd say one would be, it really gets down to alignment. So ultimately, when you're in an APM contracting situation, you need to have mutually aligned objectives. And I'll be very brutally frank on this. We have a number of large vertically integrated health systems in the Minneapolis area, and I think a real challenge with APM contracts is asking them and to really push to an area we want to push them to, which is essentially taking costs out of the system in a material way. And a real challenge is sort of negotiating how far they're willing to go in doing that. And that probably comes down to every negotiation that we have is in that area. So no surprise there, but that's still a real challenge. And quite frankly, that's, I think, an important element of MACRA is will it create that tipping point within the provider community, particularly in the hospital setting, where they're going to be incented of not putting people in hospital beds, and that's the bottom line. So that's a big challenge, ongoing challenge. Secondly, I'd say would be around quality, really setting the quality measures and setting the right quality measures, setting quality measures that may be more important to the payer and maybe less important to the provider. So getting alignment around what those measures should be and how much you're willing to either create a withhold around or create some type of incentive around. I think that's another challenge. I think a third challenge is really around delegation of services. Who's going to be accountable for what within the APM contract? So ultimately, these are a negotiation, but you go in with good faith and you try to find the areas of common ground, neutrality, and continue to work it. Again, that's why, as you think about the time and effort, particularly of our contracting teams and people within our business segments are spending a great deal of time on this. What we don't want to have happen is have MACRA create a whole other set, if we can avoid it, of other things that the providers are going to need to focus on related to quality. And so aligning the great innovation that's happening within the U.S. healthcare market in this type of contracting and leveraging that and bring it into the MACRA universe, I think, again, is one of the key asks that the payer community had as CMS.
Thanks, Andrew. Your mention of quality measures actually segues nicely into our next question. Our attendee who works in pediatrics has asked if you could give an example of a quality measure that could be a possibility under MACRA.
Oh, on a pediatric standpoint or any? I'm probably going to be a little bit outside of my comfort zone in terms of giving you specifics on some of the differences between STARS and MIPS in terms of what we're specifically asking for. I'll be, brutally honest, my focus largely is around STARS and making sure that we're executing around those particular measures, whether they be outcome measures or the other types of measures. So I probably don't have the skill set to go deep into promoting or suggesting quality measures under MIPS.
Well, we appreciate you giving us a try. So our next question is actually for Harry. So there's been a lot of media coverage around MACRA, and particularly around Andy Slavitt's recent comments that he would consider a delay in implementing MACRA. So what do you think is going to happen? And feel free to chime in as well, Andrew. And if it does get delayed, how does that lessen, or doesn't that lessen the urgency of getting ready for this January 1 date?
There's been a lot of press around this, and as Andrew mentioned, Andy Slavitt did appear in front of the Senate Finance Committee last month, and there were untold number of stories coming out of that. The headlines all focused on the fact that he mentioned he would be willing to delay MACRA implementation. At the same time, even in some of the comments that Andrew is reading and that have been published by some of the large constituents, such as American Medical Association, American Hospital Association, even those organizations are asking for a nominal delay of 6 months, in some cases a 12-month trial period. So, and also when Andy Slavitt spoke, he talked about the fact that CMS is actually putting money aside to help some of those smaller and rural practices get up to speed, get some of the technology infrastructure and some of the other resources in place that they need. So as Andrew said, CMS is committed to making this happen, and they're investing money and resources. They've done, according to them, they've spoken in person with 64,000 different stakeholders across in the past year since the law was put in place to get feedback. So our point of view is it's going to happen. It may encounter a nominal delay, but if anything, that additional time should be viewed as time to spend focused getting ready. So it even increases the urgency. That would be our opinion.
Andrew, another question. Oh, go ahead. We'll wait on our question.
Yeah, the only thing I would add is, I do think we need to acknowledge that what MACRA is doing, what the ACA did was, really try to accelerate business transformation within the provider community, and this is exceedingly difficult. And so I just want to have some empathy for large systems and smaller physician specialty groups that this is not easy sledding. This is extraordinarily, frankly, difficult transformation type of activity where we're asking them to change the revenue model. We're asking them to change really how they manage patients, how they measure themselves, be transparent, essentially have that shared with the public. And this is really challenging work. And so if there is a deployment, I recognize as to why there would be, because of really the large lift that this is going to take within the provider community.
Thank you, Andrew. We have time for one last question, and Andrew, I think this one's coming to you. What tools are being used to calculate the complex formulas needed for value-based payments?
Many tools. There's all kinds of homegrown tools within health plans. There's consultants that that there's entire organizations that are built around this. So I think that is also a challenge, is that there's not maybe one set methodology that is used industry-wide, and as payers, we come to providers with our own unique view, our own unique calculation. This will hopefully get MACRA is an attempt to create some uniformity around this, and one might think that under the APM measure come 2021, that even Medicare Advantage contracting may look more universal because of the definitions within the all-payer APM track, that you could, I could imagine a world in 5 to 10 years from now that Medicare Advantage contract between payers and providers are very common and very similar, and more universal and more consistent. But again, to answer the question about how are these calculated, it's all over the board.
Great. All right. Well, we are just at the top of the hour, so I wanted to take this opportunity to thank Andrew from Medica and Harry here from HealthEdge, as well as the folks from the HCEG, the Healthcare Executive Group, for helping us put this webinar on today. And thank you to our attendees who've lasted a whole hour with us. We hope that you found this informative. We'll be making a recording of today's webinar available, and you can look to find that on the HCEG website following this event. Thank you.